Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends. Welcome to another episode of the Healing Pain Podcast. This week, we're discussing how to bridge the gap between the mind and the body in pain management and pain medicine. My expert guest this week is pain psychologist Rachel Zoffness. Rachel is a practicing clinical psychologist and an assistant clinical professor at the University of California, San Francisco School of Medicine, where she teaches pain education for medical residents. She serves on the boards of the American Association of Pain Psychology and the Society of Pediatric Pain Medicine, and is a 2020 Mayday Fellow. On today's episode, we'll discuss the essential role of pain education, how health providers of different disciplines can use pain education in practice, and how to apply the biopsychosocial model framework for the treatment of chronic pain. Okay, let's begin and let's bridge or eliminate that gap between the mind and the body. And let's meet Dr. Rachel Zoffness. Hey there, Rachel. Welcome to this week's episode of the Healing Pain Podcast. It's great to have you on.
Hi, Joe Tatta. Thanks for having me.
I'm excited to chat with you.
Ditto.
About all things pain.
Totally.
Kind of dig into some of the nitty gritty of where we are, how far we've come, how far we still have to go.
Indeed.
Both in our healthcare professions, all of our healthcare professions that are treating pain, as well as what we need to do to help people cope with pain out in the greater world. Let's start here. What are we currently not doing in the realm of pain management that we should be doing to help people?
Where to even begin? I guess I'll start by saying I think the biggest problem that we have in pain is that we've erroneously framed it as a biomedical problem for many, many decades. And by that, I mean, we've framed it as a purely physical, mechanical, anatomical problem. And what's amazing and astonishing about that to me is that you don't even have to dig very far in the literature to see that for many decades, actually, science and neuroscience reveals that pain is actually biopsychosocial, right? Like all the theories of pain, all of them, as far back as the gate control theory in the 60s, point out that thoughts and beliefs and emotions and coping behaviors and social factors and contextual factors all implicitly affect the pain that people feel. But for some reason, when we treat pain, and this has been going on for decades, we treat it as a purely biomedical problem with biomedical solutions, right? So we throw pills and procedures at pain all day long. Doesn't matter the age of the patient, doesn't matter their diagnosis. And I know I'm preaching to the choir here, but it's not working. Incidence of chronic pain is on the rise. We're in the midst of an opioid epidemic, which is getting worse during our pandemic, right? COVID is like, we're seeing spikes in pain and spikes in opioid overdoses. It's an absolute disaster. So what are we not doing? We're not framing pain accurately. I mean, if people like you and I had billion-dollar budgets like Big Pharma, I think we could probably bet that pain would not continue to be framed as a biomedical problem, but we don't. The psychosocial treatments for pain are stigmatized. They're not popular. They're seen as, treatments that are only for people who are crazy or only for people with pain who have comorbid anxiety or trauma and depression. That's not actually accurate. So what's actually happening with pain is that it's a biopsychosocial problem, right? There's these three domains, but we're only targeting one of them. So literally we're missing 2/3 of the pain problem.
How do you explain, so the word biopsychosocial has been used on this podcast thousands of times. I use it all the time. I had someone on just recently. I'm not sure. It'll probably air by the time this episode airs. And he was saying, we just need to scrap the entire word biopsychosocial because it doesn't accurately explain what's happening with regard to pain. And I'm not sure we want to get into that on the podcast today, but how do you describe biopsychosocial? Let's take health professionals first, because not all health professionals have pain education or pain training as part of their curriculum. And in fact, those that may be perceived as the top of the food chain in the medical world, i.e. physicians, have some of the lowest rates of pain education and training in their medical training, but the public actually may have a different perception of what's happening. But how do you, I know you do some training with physicians. How do you explain what biopsychosocial means to a physician with regards to chronic pain?
I am so curious to hear the argument for why we need to scrap the term biopsychosocial. I personally think it's wonderful and very helpful. The reason why I like it is because it offers a more comprehensive, all-inclusive picture of what's actually happening with a human being. Because in the center, it doesn't actually matter what you have in the middle of that Venn diagram. It can be cancer, and it can be anorexia, and it doesn't matter what you. It could be depression, it could be pain, it doesn't matter. But all human health problems are this thing that we call biopsychosocial. The reason I actually love the term is because you can easily trot it out and explain what it is. So you've got the biomedical domain of the thing. In our case, we're talking about pain, right? So that's a lot of things. It's genetics, and it's tissue damage, and it's system dysfunction and anatomical issues, and it's sleep and diet and exercise. And all those things are critically important for pain. Of course they are. And no one would argue that they're not. But then you've got the psychological domain of pain. When people shorten it, sometimes they call it the psycho domain of pain, which is one of my big pet peeves, because you don't want to amplify the stigma anymore. Psycho, we should do away with psycho maybe. The psychological or the psych domain of pain is thoughts and beliefs and emotions and coping behaviors. And even past pain memories. If you do research or look at the research on pain memories and the role of the hippocampus in pain, it's huge. It's wild. So to pretend that thoughts and beliefs about your body and about your pain don't actually affect your experience of pain is ridiculous. The research is many decades old. And then you've got the social domain or the sociological domain of pain, doesn't really matter. And that's family system and your larger context and your race and ethnicity and religion and community and your larger environmental context. And of course, we know that also impacts the pain you feel, right? So to say that pain is not biopsychosocial, is purely biomedical, we know that that's wrong. To not use that term, I'm not really sure what people would recommend replacing it with, but I'm all for using a term that's easily digestible. People are great with visuals. The biopsychosocial bubble thing works really well. When I do trainings, I've never had anyone not get it. I use it with kids in my office as young as 8. I find it to be very descriptive. I usually have people actually tell me what they think their biopsychosocial, either the triggers are, the things that hurt and the things that help their pain. So I actually think it's a great descriptor of what's happening. And just to say, I'm teaching med school at UCSF. The physician trainees are all in. They already believe, this next generation, they already know and believe that all health is biopsychosocial. Of course it is. This is not new information. But when you give them that term, then they trot it out and they teach it to their patients. I think it's actually a really useful tool for framing health problems.
For those of you who want to explore this a little bit deeper with regard to the biopsychosocial model and alternatives, you can check out the interview with Peter Stilwell, which, as I mentioned before, I'm almost 100% positive will be available on the blog at the Integrative Pain Science Institute. Now, he's a pain researcher, and one of, shall we say, the criticism of the biopsychosocial is that it rolled out in a nice way in the research, as you mentioned, many decades ago. But somehow, as those 3 spheres were rolling out, they got kind of separated into a bio, a psycho, and a social. And of course, I slowed those words down because kind of within those, columns or 3 spheres, if you will, we then have the deconstruction of really that model that has happened in certain places within our healthcare system and certain at times within a practitioner themselves. Like one of the things that I am so passionate about teaching professionals is you don't have to work in a multidisciplinary clinic to provide biopsychosocial care. That there are ways that you can achieve that yourself through professional development and working with patients to integrate the type of care into your clinic. But that's the one concern, that there's not an embodiment of that model, either in our healthcare system, in our individual practice, and by those at large.
So 2 things. I agree 100%. So thing 1 is the problem that we're calling it a biopsychosocial issue, that is pain? Is that the problem? Or is the problem that the way we treat human beings in Western medicine is broken? And I will humbly submit that the word is not the issue. And I actually totally agree with that perspective. It's actually part of my, like when I get on my soapbox, one of the major problems we have with pain is that we are all siloed in our own separate disciplines, right? We've got like PT over here and OT over here and psychology over there and anesthesiology over there and physiatry over there. We're just all, but we're all treating the same patients and the same issue at the end of the day. And collaboration just isn't, it's not happening sufficiently. So part of the problem in my mind is that in Western medicine, people either have physical pain and they see a physician and maybe a PT, they're lucky, or they have emotional pain and they come to someone like me. I'm a pain psychologist, right? But we know that that's not how pain works. It filters through the brain's limbic system, your emotion center, 100% of the time. So pain is always physical and emotional, right? So we have this problem in Western medicine where we're artificially dividing and funneling people down these separate pathways when in truth, that's not actually how pain works. So I'm not sure the problem is actually the term, but I am open to all suggestions because we're definitely doing a lot of things wrong. So if someone has a better idea and a better term, bring it. I'm all in. I mean, I think at the end of the day, we all need to be collaborating and talking and doing stuff like this and having conversations and moving the needle. I think that's actually what needs to happen. I don't know if the word is the problem necessarily.
Earlier in this episode, you mentioned stigma around the treatment of pain. And there's lots of stigma attached to pain in many different aspects and included in the biological, the psychological, and the social. I think the psychological perhaps sticks out a little bit more because we know that chronic pain is not a psychological disorder, but we know that mindset is very important with regard to treating pain. When a patient first approaches you or they're kind of tiptoeing around the idea of seeing you, how do you describe what you do in a way that destigmatizes treatment for them?
There are so many things I want to address about the thing you just said. Yes, there's a ton of stigma around people living with chronic pain, just that. Yes, there is a lot of stigma around this suggestion that chronic pain is somehow like a psychological disorder or that any like comorbid anxiety or depression is a sign that people with pain have mental illness. Totally and 100%. So there's a couple of different things that I do. One is that I tell people who are referring to me to call me a pain coach. And the way I pitch it, and I see, I actually see patients of all ages. My favorite age group happens to be like the teen, tween, young adult group, but I see older adults and younger kids. And the way I pitch it to everyone, patients and providers alike, is that if it's okay to go to a soccer coach to get better at soccer, it is surely okay to go to a pain coach to get better at dealing with pain, because pain is really hard to deal with and everyone living with pain deserves support. So that takes some of the sting out of it, because there's no way that I am going to be able to pull the stigma out of seeing a psychologist, a mental health professional. And by the way, for people listening, I am air quoting hard with my fingers. And someone who treats, physical pain versus emotional pain, right? So I'm not going to be able to remove that stigma on my own of seeing a psychologist for a physical problem. However, I think using the pain coach language is really helpful. That's thing one. Thing two is I really like to remind patients and providers alike that when we see signs of stress and anxiety and low mood in our patients, that is natural and normal. It's what we call a normal response to an abnormal situation. It's like, for example, if there were a pandemic, let's just say, and you had absolutely no stress and you felt 100% totally calm all the time, that would be more weird. Of course, you feel stress and anxiety with a situational trigger like a pandemic. It's the same with chronic pain. Pain is one of the biggest stressors on the human body. Moving across the country is a stressor. Death of a loved one is a stressor. Being in pain all day, every day is a stressor. Of course, you have anxiety and depression when you're living with pain day in and day out. Your body's not built to be in pain for months and years. That's not, so when you lose your social life and you lose your sex life and you lose your ability to engage in hobbies and pleasurable activities, your mood crashes, your stress and anxiety system activates. Of course it does. So again, I am of the mind, and I get to say this because I'm a psychologist, that is not actually truly mental illness at all. Actually, that's a normal response to an abnormal situation. And what I see with my patients is that when we treat their pain in a biopsychosocial framework, anxiety goes down, depression goes down, functionality increases, and that quote unquote mental illness thing magically resolves. So I think there are ways of talking about it. I think the problem is that we don't talk about it. We don't talk about the stigma. And we should all be doing that up front. So like, hopefully people will be referring more to psychologists and biofeedback and these other psychosocial treatments, but they'll hopefully be doing it in a way where they say to their patients, listen, there might be some stigma around this for you, but I just want to say up front, I don't think you're crazy. I don't think it's all in your head. I don't think you're faking it. I don't think you're making it up. And I think that conversation needs to be had because so many patients report getting that message, either overtly or interpreting it that way.
What's your opinion on physical therapists and other licensed health professionals using principles of psychology in their practice? And if they are, how can they overcome the potential cognitive dissonance that happens when a patient comes to them? And for example, if you come to see a physical therapist, you may expect exercise and physical activity, and you may not expect that, wow, in addition to that, we're going to do a little mindfulness exercise.
Right. I had a feeling you were going to ask me that. And I actually think that's an important thing for us to talk about too, because here we are talking about our silos, PTs to the left and psychologies to the right and medicines down the hallway. So this is just my humble opinion. You're asking me for it. I do, of course, think it's important for us to stay within our professional boundaries. Like, I would not perform surgery. That would be insane. However, I absolutely 100% think it's appropriate and important for physical therapists to be using some of these strategies, because you guys are pain coaches, just like I'm a pain coach. And I bet there's things that you're doing that I can and should use. In fact, I do pacing with my patients, which is something I pulled from the PT literature. I use PT stuff all the time. Like, Laura Mosley and Adrienne Lowe are two of my pain science heroes, so I definitely think that PTs can and should be using some like nuggets from pain psychology. Absolutely. Do I think that PTs should be calling themselves, mental health providers? No, that's not appropriate. Do I think that PTs should go around saying, like, I can give you an entire course of cognitive behavioral therapy? Probably not. If you're not licensed to do it, you probably can't do a whole course of CBT. Can you use strategies? Absolutely. Should you? In my opinion, yes. Sometimes your patients are not going to get to see a pain psychologist. So I'm all about having a tool belt with as many tools as you've got and offering your patients things that might help them. And then they get to decide what they implement and use. So yes, use mindfulness. Absolutely. Use some cognitive strategies, use some behavioral strategies, use behavioral activation. Totally use that stuff. I use your stuff. You should use mine,
The flip side of that would be, as we're kind of breaking down silos rapidly during this episode, how do we encourage mental health professionals to use physically informed psychology?
Say that differently.
So as a physical therapist, as you well know, the literature has grown with regard to physical therapists adopting principles of psychology in their practice, right? So that basically makes a physical therapist practice multimodal. So in essence, we're taking interventions that maybe only have minimal results and outcomes. And then when we combine them, we're more likely to get moderate and maximum effect sizes. Knowing that exercise is powerful pain medicine and not only helps physically, but also helps psychologically and emotionally in all those three spheres that we're talking about, actually, the biological, the psychological, and the social. How do we encourage psychologists? And I've had these conversations at a couple of meetings I've been to with psychologists present, and sometimes it goes over well, and sometimes it does not go over well at all. But I guess I should just come out and say, because I know, Rachel, you and I are kind of on the same page with these things. The idea that seeing a patient who has a problem with physical function and only sitting and talking to them twice a week for 8 to 14 weeks, are we then not helping them with the behavioral activation that they need and the exposure that's required for them to take it out of our room, take it out of the therapy room and place it into their life?
I got it. So two things about that. One is that, I sit here all day and talk about how pain education is lacking across disciplines and how 96% of medical schools in the United States and Canada have zero dedicated compulsory pain education, which blows my mind. But one of the biggest offenders is psychology. I went through, I'm a nerd. I'm like a capital N nerd. And I was in school for 40 billion years. And luckily, as an undergrad, I had the best neuroscience class at Brown. And we talked about pain, and I ended up doing my honors thesis on pain and going down the rabbit hole. And I was so fascinated by it. But in the years since, I got 2 master's degrees and a PhD in psychology and an internship and a postdoc. Physical pain did not show up again until like my postdoc. I mean, and it was only because I was all about it and I wanted to go down that rabbit hole. So in general, psychologists are not trained in pain at all. They are not trained to bridge this gap between physical and emotional, to bridge the gap between medicine and psychology. That's true also in health psychology programs, many of them. There are some pain psychology programs, but there's very, very few. So the answer is that we need to train more mental health professionals, not just psychologists, but social workers and MFTs in pain science. That just needs to be part of every program because, as you know, patients who show up with just anxiety or just depression or just trauma, emotions don't just live in your head, they also come out in your body. So all of these quote unquote mental health conditions have physical components, and all therapists, in my very humble opinion, which is also a very strong opinion, should be trained to address pain and somatic symptoms. That would be a more integrative provider, sort of what you're saying. So that's thing one. Yes, we need more training in psychology. I forgot the other thing that I was going to say, actually.
So let me just rest on that point for a minute.
Yeah.
So I think in many ways what you're saying is that cognition.
Okay, go ahead.
Cognition is embodied,
Mm-hmm.
which basically
That's
helps. If we're kind of along the same line here, when I say cognition is embodied, it helps us remove the idea that cognition happens from the neck up when your nervous system is not just your brain, right? Your nervous system is your entire central nervous system, your peripheral nervous system, your sympathetic, parasympathetic, enteric, etc., which is throughout your entire body. So if we look at cognition being embodied, then we have to treat the mind as well as the body, no matter which type of practitioner you are.
That's right. And the best way I found to teach that, by the way, is a little thing called biofeedback, which I'm obsessed with and use in my practice. In biofeedback, you sit in a chair, and if you're me, a very nice and elderly biofeedback provider will tell you that he is going to teach you to warm your hands to 90 degrees. And if you're me, you say, but I am a scientist and I do not believe in voodoo. And then while you're hooked up to this machine, you are watching. He'll use techniques to change, you're thinking certain thoughts, like particularly stressful thoughts, and your hand temperature, for example, will plummet and muscle tension in your body will spike. And you'll be like, oh, wow, the things I think in my head are inherently, inextricably linked to the sensations and things that are happening in my body. And then in 2 sessions, you're able to warm your hands to 90 degrees. It's pretty magical. So biofeedback is pretty great. The thing I was going to say before that has come back to me, I'm elderly and my memory is not what it once was, is that CBT, which is cognitive behavioral therapy, and not CBD. Sometimes people think I'm talking about medical marijuana. I'm not. Cognitive behavioral therapy is sort of my ace in the hole when it comes to treating chronic pain. I find it to be incredibly, hugely effective and useful for my patients, in part because it's teaching tools for pain management and skills for life, but in part because it is making this connection between brain and body, between thoughts and emotions and physical sensations and pain, and it's offering patients a modicum of control over their bodies and over their brains. So in CBT, to your question, I have my patients pick a thing that they want to do during the week. It's like, I try not to use the word homework because people would never talk to me again, but it's the thing that happens in the spaces between. I get people once a week, right? So what happens in the space between? So the thing that I'm often recommending is something that's physical in nature. You have to go walk around the block or whatever it is. It's part of their pacing planner. So to your question, how do you link the 2 things? You train more mental health professionals, social workers, marriage and family therapists, psychologists to be integrating treatment for pain medicine into any sort of psychologically informed approach, because we shouldn't be so separate and siloed, because then we're not practicing biopsychosocial medicine, which is exactly what I think you're saying.
So you're a big advocate of cognitive behavioral therapy.
Yes.
You mentioned that you see huge benefits for people in your clinical practice when you use it. A couple of weeks ago, there was a psychologist on who is primarily a researcher, and she's done 2 Cochrane systematic reviews and meta-analyses on CBT for pain specifically. And her outcomes are kind of the same in both. And the reason I'm asking is I've got a number of questions from listeners and viewers, listeners on the podcast, and viewers for those of you who watch our videos, that her results say that CBT has minimum effect sizes and outcomes for people living with pain. Now, if you're someone who has pain, you might think in your head, okay, well, there's minimal, moderate, and there's maximal, right? If you're someone with pain, you're kind of like, I want to find the person who has the maximal results. I don't want this minimal type stuff here. Like I'm in pain. I've been suffering for a long time. It's taken me a long time. And finally, someone has now recommended something for me, and you're telling me it's minimal.
I have an answer for you.
Shoot.
I think about this a lot. I think about this as a provider. I think about this as someone who has lived with pain. I think about this as someone who is a nerd and reads research literally like all day long for many, many years. So what we learned in our very dorky research-based PhD program was that when you're reading research, you never just look at the conclusion, never. You always look at how the research was done. And when you're comparing research studies, especially meta-analyses, you actually want to look at what's being compared. So I'm going to give you some issues that I personally have with the CBT literature. I love meta-analyses, by the way. I think they're very helpful, but I also think we need to actually research the research that we're reading before we come to any sort of conclusions. So if you look at the papers that are included in meta-analyses, there is no one standard operational concrete definition for CBT. You ask 10 different people, you will get 10 different answers. So there's like not one manual that everybody's using. So everybody's using a different manual. Everybody's using different strategies. There's no operational definition. So what are we actually measuring when we talk about CBT? So that's problem number one. Problem number two is, what is the length of treatment? Like one study has it for 8 weeks via an online virtual treatment platform. Another one's doing 12 weeks in person. The length of time is not standard across studies. Thing three, who is the provider providing the treatment? In some research studies that I've read, it's some unsuspecting grad student who has signed up to work with a researcher, and they're suddenly saddled with providing some sort of treatment they've never done before. In other studies, it's a social worker. In other studies, it's a seasoned pain psychologist. And what we know from the psychological literature and the pain literature is that the provider matters, right? There's all these provider factors that feed into the treatment efficacy. So we're never comparing apples to apples. What we can say about cognitive behavioral therapy is that if you break it down into its component parts, there's abundant research that supports each of the component parts, which is actually how I go about CBT. So cognitive strategies for pain are actually pretty effective. Behavioral strategies for pain, pretty effective. Exercise for pain, pretty effective. Pain education, which I'm sort of obsessed with, also pretty effective. So if you look at the component parts, biofeedback for pain, which is part of what I do, mindfulness for pain. So there's all these different parts. I think it sort of depends on the recipe that you're using. So I sort of balk whenever someone says to me, well, this paper says that CBT for pain is super effective and this paper says it's minimum. I'm like, well, what are we actually measuring? I think we need to come up with some sort of operational definition of CBT before we can pretend we're actually measuring something. Because it's like some sort of CBT soup out there. Like, I don't actually know what anybody's really measuring. It's certainly not consistent across studies.
I think that's really well said. And I actually asked her that question because, as you mentioned, CBT can be, you said it really well, 7 to 10 to 14 sessions. I had asked, I said, well, how much of that CBT also included like lifestyle type interventions like sleep and nutrition, which sometimes are part of a longer CBT intervention. And sometimes they're just kind of left out because it's not a pure cognitive approach or model. And, I think the right answer is, if she were to go back and look at those studies, or if we were to go back and look at those studies, sometimes they mention them in the actual paper, but 99% of the time they don't.
You and I should write an article about
that. I think we're writing one right now, actually. We're transcribing as we're speaking.
Yeah, totally.
The other thing that came up in that paper was there was a commentary about ACT, acceptance and commitment therapy for chronic pain. And one of let's just get to the point. The conclusion of our paper was that the CBT literature has more evidence, and we should kind of stick with that and wait for the evidence on ACT to build, so to speak. And a lot of people who follow this podcast, because we talk about mindfulness, we talk about ACT, we talk about everything, of course, on this podcast. They, of course, asked me, what do you think about that? And what do you think about ACT? And you teach ACT, and et cetera, et cetera, et cetera. So I'm curious from your perspective, what your thoughts are on that.
I always go back to the thing where I feel like what I want to do most is offer my patients as many tools as I can that I have personally vetted, that I've gone down the rabbit hole, I've read the things, I know it's not, hooey, and it's not pseudoscience, it has some evidence. And at the end of the day, the best thing we can do is offer some strategies. If it doesn't take, it doesn't take. There's some of my clients hate mindfulness, which I get. I totally get it. That's fine. If it's not your thing, and some of my clients, it changes their life. It helps them get out of bed and face the day. So yes, let's try act with our patients. I literally can't think of a reason other than that. Yes, there's not a fund of literature, but it's not like, it's not like a pill where if you take it, your liver might fail. There's really like the side effects of trying act with a patient are pretty minimal, if any. So I feel like we really just don't have that much to lose and a lot to possibly gain. So yes, let's disseminate tools and resources if we have them. I can't think of a great reason not to.
It's also interesting to me because a lot of those cognitive behavioral interventions have mindfulness as part of them.
Of course they do. I mean,
and mindfulness is oftentimes is kind of, trait or implicit in some of the things that we're doing with people, whether you're coming from a very traditional cognitive behavioral or like a more third wave type interventions. So it's interesting that doesn't really show up, as you mentioned, in the literature either. And I think even just, breaking things down into mindfulness versus ACT, and, there are these processes, and there's diffusion or there's decentering, there's so much, as you mentioned before, there's an alphabet soup that happens after a while.
Yeah, well, so the thing about ACT is that it's an offshoot of CBT, right? It grew out of CBT. So there's a lot of overlap. And at the end of the day, this thing that we're calling cognitive behavioral therapy, in my mind, especially for pain, is an amalgamation of a lot of different things that we found to be effective. Just back to that thing we were saying before, that yes, there's cognitive strategies that have been shown in the literature to be helpful for pain because your cerebral cortex and your prefrontal cortex impact the pain you feel 100% of the time. So let's change those brain structures to help your pain. At the end of the day, what we're actually doing is this little thing we call neuroplasticity. We're changing the brain to change the pain. If you don't do that, nothing's going to change. Of course, you need to, the body is important too, which is what you're talking about, doing pacing and involving PT, but CBT is become this sort of mishmash of all these different pieces of the puzzle. So the lifestyle component of CBT is one of the things that I actually end up going after first. I have like a really dorky sleep hygiene handout that I give to everybody, especially my teenagers, because they're up till 4 a.m. and sleeping till 2 p.m. But yeah, it almost doesn't matter what we call it. So I'm up at Dartmouth right now. I've started consulting here, believe it or not. And I met with this wonderful pain neuroscientist. His name's Tor Wager, and I love his research. You've probably read it. And he and I were talking, there's another therapy that's being developed now that is, in my mind, exactly the same as CBT. It maps almost 1-to-1, but it just depends on, again, the problem is that we don't have operational definitions for the therapies we're using. That's problem one. And problem two is that people are so territorial about the names of things. Like it either has to be ACT or it has to be CBT or it has to be this new. And like at the end of the day, we're all doing the same thing. We're providing pain education. We're helping patients change their thoughts. We're helping them engage in healthier behaviors and break unhealthy habits. We're helping them have a healthier lifestyle. So I don't actually care what we call it at the end of the day. Like it seems like we're all doing the same thing.
When I interviewed Lorimer, you mentioned pain education. This is way back when, because I've been around I've been a PT for a long time before like the pain education phenomena that we have now. So we were still doing pain education back then. We just didn't necessarily have a word for it, so to speak, just like, there are multiple types of cognitive behavioral therapies. But I asked him during the interview, because I haven't heard him or other professionals really say this, is pain education a form of cognitive behavioral therapy? Like, have you taken it to that place yet? And he very intelligently kind of turned it back on me and said, well, did you learn about cognitive behavioral therapy when you were in physical therapy school? And I said, no. When I went to PT school in 1995, that wasn't on the radar at all. It probably wasn't even on most pain psychologists' radar at that time. It was just kind of start of that. But he did kind of arrive at the place where, yeah, pain education is a form of cognitive behavioral therapy because you're helping people with their thoughts and beliefs and how it relates to their behaviors and obviously their physical outcomes after that. So when you look at pain education, does that fit something that CBT or ACT hasn't been able to address? Or is it just kind of like, as I mentioned, we kind of have been doing this, we just now have like a fancy name for it?
If I remember correctly, Lorimer wrote a paper on why pain education is not CBT. Like he had some very strong language around that. I'm going to need to go find that. And there was like a table. So I asked him that also. So I do think that there's a difference. So I would say, the way I would say it is that, again, I don't care what we call this thing, but the thing that I'm doing, what I'm calling it is cognitive behavioral therapy. It doesn't matter at the end of the day. But one of the most important components of CBT is pain education. And for me, that comes first. I don't do anything else with any patient until they understand their pain. Why? Pain is a ubiquitous human experience, and every patient and every provider should understand pain. It's never taught. It's not taught in doctor's offices. It's not taught in med school. It's not taught in PT school most of the time. It's not taught in psychology programs. So it's the first thing I teach. Pain education to me is the foundation for everything else. If you don't understand that your cerebral cortex and your thoughts and your limbic system and your emotions impact this physical thing that we're calling, this physical experience that we're calling pain, then at the end of the day, you're not going to buy into what Joe Tatta is doing, and you're not going to buy into what Rachel Zoffness is doing, and you're not going to buy into you're just not going to buy in. So in my mind, the pain education piece has to come first. And then there's a lot of other things that grow from there. So I do think a very big part of what I'm doing is sort of being a private detective. In any given moment, I'm trying to figure out the biopsychosocial puzzle of the person sitting in front of me. So what are the contributing factors to their pain? Certainly there are biomedical contributors, and those are the things 9 times out of 10 that have already been treated and medicated and surgeried. And then there's the whole psychological domain. So what are their thoughts and beliefs about their body and about their pain? What are their past pain memories? What's going on with their trauma and their anxiety and their stress levels during a pandemic in particular, and their mood, and how is that feeding the pain that they're experiencing? And what can I do to help them with that? And then the social or sociological domain of pain, the same. What are the family factors and the contextual factors that are amplifying the pain that they're feeling? So yeah, I definitely think absolutely CBT is a lot more than just pain education. I don't think that's sufficient. I think pain education is critically important, but I don't think it's sufficient.
When you're using CBT, is it you just have 1 or 2 sessions dedicated to that, or does that become a through line that happens throughout the entire treatment with the patient, or is it more in the beginning and then tends to wane as you see that people have, in essence, reconceptualized? How do you approach that?
Yeah. Okay. So I said this before, I'm a huge advocate of pain education. And to that end, I'm always trying to think of language and words and ways of framing pain and pain neuroscience that are going to be impactful and helpful. But I have to admit, I do this sort of selfishly, trying to think of ways that I can explain pain that will increase buy-in and motivation to try these treatments that I think are so helpful. And again, if a patient does not know that their thoughts and emotions or amplify or decrease their pain, they're not going to do anything I'm suggesting, right? So one metaphor, pain education is a thread throughout. It begins at the beginning. So the beginning sessions, always pain education heavy, and it goes through the entire course of treatment. With some patients, it's like 6 sessions or whatever. And with some patients, it's 6 months. It just depends on the person who's sitting in front of me. But I always offer a metaphor, and this is the metaphor that I use. This is the metaphor I always use with anyone who comes into my office. Ready? And it's the thread throughout all of our treatment. I want you to imagine in your central nervous system that you have a pain dial. It's like the volume knob on your car stereo. And the pain volume can be turned up and it can be turned down by lots of different factors. 3 in particular. 1 is stress and anxiety. 1 is mood. And 1 is attention, or what you're focusing on. So there are lots of factors that amplify or decrease pain volume, but 3 in particular. So here's how this works. Ready? When stress and anxiety are high and your body is tense and tight and your thoughts are worried, your brain sends a message to your pain dial, turning pain volume up. So pain feels worse when stress and anxiety are high. 2 is mood. When mood is low and you're miserable and depressed and emotions are negative, your limbic system sends a message to your pain dial, turning pain volume way up. So pain feels worse when mood is low and emotions are negative. And thing 3 is attention. So when you are in bed, focusing on your pain, You're not going out, you're not doing anything, you're not engaged in life. Your prefrontal cortex sends a message to your pain dial, amplifying pain volume. So pain feels worse when you're focusing on it. But the opposite is also true. And this is so important for people with pain to know. No one's ever told them this before. When stress and anxiety are low, your thoughts are calm and your body is relaxed, your muscles are relaxed. Your brain sends a message to your pain dial, lowering pain volume. Pain feels less bad when stress and anxiety are low and when you're managing it. Thing two is mood. When your emotions are positive, you're happy. You're engaged in your life, you're engaged in pleasurable activities. Your limbic system turns down your pain dial, lowers pain volume. Pain feels less bad when your emotions are positive. And three is attention. So when you're distracted, when you are engaged in your life and you're out doing things and you're with friends and you are moving your body, your brain will lower your pain volume. Prefrontal cortex turns down the pain dial. So the reason I share that metaphor here and with my patients is because that gives me traction. From that moment on, every single session, I ask my clients what they did that week to lower their pain dial every week. And that becomes the thread of everything else. That's the foundation. So if they don't know that there's a pain dial that's affected by thoughts and emotions and behaviors and lifestyle choices, what do I have? How are they going to buy in? How are they going to take my advice?
I love that metaphor. Can I add a dial to your dashboard?
Totally.
So I love that pain dial, and everything you said. Everyone should go back and rewind that and read through it because it's all dead on perfect. And then sometimes, even with all that, for certain people at certain times of our life, depending on certain environments, sometimes those things may not work so well.
Totally
So we have control of the pain dial, but we also have another dial called willingness that we can control. And sometimes, even when you have pain, you can still turn that willingness dial up, even in the presence of pain, if it's towards something that is deeply meaningful, important, and that you love in life. And sometimes that willingness dial is just as important, or I kind of look at you're constantly kind of adjusting these two dials. What about the biopsychosocial lifestyle factors, the behavioral change factors can I adjust on that pain dial? And then as I'm doing that and I'm experimenting with this, how do I adjust that willingness dial and ratchet that up just a little bit and know that this process might be 2 steps forward, 1 step back sometimes, but eventually you'll wind up at a place where the pain dial is lower and the willingness dial is higher.
I love that so much. And I totally agree. And sometimes I feel like my job is a motivational interviewer. And you're right. That's a lot of what ACT is also, right? So totally. I agree that values-driven behavior is critically important for everything. But yes, especially pain. And a lot of our patients are dealing simultaneously with addiction and other issues. So yeah, motivational interviewing and willingness, that's huge.
We didn't get into the addiction aspect of it. Can we touch base on one topic with regard to that?
What did you say?
Can we touch base on one topic with regard to addiction?
Sure.
It became really apparent to me that we were ripping the carpet out from underneath people a couple of years ago when we decided to not refill prescriptions, aggressively taper when there was no need to taper when the prescriber didn't understand how to taper or look at the biopsychosocial factors that are involved with tapering. What's your advice to someone who potentially has been on an addictive substance, and there are many of them, and they're thinking about tapering, but they're just scared because they know that it's difficult to find someone to help them taper down appropriately and to help them cope with what may happen during the taper?
Totally. Tapering is admittedly not my area of expertise, so I don't want to pretend that it is, but I actually think the biggest problem in that realm is that we are tapering people off of their one pain treatment strategy without offering them others. And there aren't enough health providers out there trained in pain who can offer them replacement tools for their toolbox. You cannot say to somebody, I know this is the one strategy you have for effectively managing your pain, but oh well, so sorry, we're just going to take it away. That's so brutal and inhumane. We have to be offering, if we're going to tell providers to taper, we have to simultaneously train them to offer equally as effective strategies. And until we have an army of health providers trained in pain, which is something that you're doing and something that I'm doing, we cannot fairly ask people to be tapering and getting off of their and not using their pain management strategies that they found to be so effective. It's unfair. It's inhumane. There's actually a book called, have you ever read Drug Dealer MD by Anna Lemke?
Yeah.
It's this quick, short read, but it is so wild. And it sort of outlines this history of treating pain with opioids and sort of brings us to where we are now. And of course, Beth Darnall at Stanford is doing some great work in the opioid tapering space. But yeah, it's a real problem that we have, that there aren't enough healthcare providers across disciplines, and that we're just tapering without offering replacement strategies. It's wild.
Rachel, it's been wonderful speaking to you today on the Healing Pain podcast. Lots of great take-homes for both practitioners and people living with pain. Let everyone know how they can learn more about you.
Yes, that thing where I said I was a nerd is actually true. I have a website. It's just my last name. It's zoffness.com. And on it, I have a resources page. And I have it there selfishly for myself, but also for everybody else. So it has books and links to other websites and podcasts, including this one. It has apps, and it has a whole bunch of things. So that's a great way of finding out more information. I'm also recently on social media. I don't love it, but during COVID, it has really helped me connect with like-minded professionals who are doing work in the pain space. So I am on Twitter. You can find me at Dr. Zoffness. Tweet at me and we can be friends. And let's see, I'm also on Instagram. I think it's The Real Doc Zoff is my handle. I'm on LinkedIn also, just my name, and on Facebook. So I'm using all the social media stuff. I also have written, I'm sort of like Dr. Tatta in the sense that I think it's really important to put pain education into the hands of providers and patients. So to that end, I've written 2 workbooks. I think it's really important for us to not just only be the holders of pain information, but to be disseminators of information. So one of the workbooks is the Chronic Pain and Illness Workbook for Teens. And the only reason it was born was because I was looking for resources for myself and for my patients, and I could find none. There are great guides for therapists who want to treat pain, but there's really not that much for patients, especially not kids and teens. So the Chronic Pain and Illness Workbook for Teens is out there on Amazon. I'm also one of those people who really advocates for pain treatment to be accessible and affordable. It's often not. That's a question that we didn't, get to, but CBT and pain psychology is often not affordable for most patients, and that's so unfair. It's just not fair. So I just put everything I do in my practice into a workbook. The workbook for providers and for adults living with pain is actually coming out on December 3rd, and that's called the Pain Management Workbook. And the Pain Management Workbook is on Amazon for something like $20. So what I'm hoping is that instead of people like Dr. Tatta and I just being the holders of the information, that actually this information can go out and be used by any healthcare provider, like literally any nurse, any PT, any OT, any physician, any social worker, any therapist, any psychologist can use the workbooks and do some of these strategies. Like Dr. Tatta was asking before, are you allowed to step out of your comfort zone and use some nuggets from pain psychology? And the answer is yes. So that's where I can be found.
Make sure to check out those resources. Of course, you can follow Rachel on social media and check out her website, zoffness.com, to access all the resources she just mentioned. And at the end of every episode, I ask you to share this with your friends, family, and colleagues on whatever social media platform you're talking on. And if you're in a Facebook group, make sure you grab the link to this episode, drop it in the Facebook group so practitioners or people with pain can access it. I'm Dr. Joe Tatta, and we'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit Integrative Pain Science Institute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.